As you know, HCC, the nature history from the acute hepatitis B, and then into the chronic hepatitis, then into the liver cirrhosis. The end stage is HCC, the hepatic tumor. So HBV infection is closely related to the cirrhosis and the HCC. More than 2 billion people in the world have been infected HBV, and over 650,000 people die from the HCC, about the 80%. So HBV induced carcinoma, I think, and also have divided two models. One is the viral oncogenes model, and the body is infected HBV, then HBV integrated into the hepatic nucleus, then transforming normal hepatic cell into the cancer and the cell. And another one is the cellular oncogene model. So it's the viral DNA integrated into the rearrangement with the HBV DNA of its host, the gene, then produce the HBV activated gene or promoter. The unconscious lead to transformation of the liver, the normal cell into the cancer cell. So how to prevention the HCC? We just classify the 3-line prevention, also the 3 measure. The first line is the etiology prevention. Because today I just focus on the relate to the hepatitis B, HCC. So the etiology prevention just indicate the prevention and suffer from the hepatitis B, such as the vaccination. This is the first line, the prevention. And the second line prevention, just the HCC, the early discovery and early diagnosis and early treatment. The third line, comprehensive treatment based on operation, just to remove the cancer. But today, I just focus on the secondary prevention of the HBV related to HCC, the early detection, the early diagnosis, and also the standard antiviral treatment and the whole cost management. So what is the high risk population for the HCC? In general, for this factor, the men and over 40 years old and the surface antigen or e antigen positive, and genotype is the C, and the high HBV DNA load, and the long-term intake of the alcohol, and with the cirrhosis background or family history of the HCC, but now also find the diabetes also is the HCC, the high risk factor. So for this population, we should regular physical examination every 3 to 6 months, and such as this the liver function, HBV serological test, HBV DNA load, and also the tumor biomarker, AFP and APT, even the GP73, and also the imaging technology such as ultrasound, and if necessary, we also do the liver fibrosis the detection or liver and liver the passage, the histological change, the diagnosis. So if above this detection have a problem, we should furthermore examinations such as enhancing CT scan and MRI. So, second way is standard antiviral treatment, the early standard antiviral treatment. This is the figure just show if the treatment with the antiviral treatment, and this patient, the cirrhosis and the HCC low down, then the control group, this the his control group never using the antiviral treatment. So we can see, and the 3 and the 5 years the accumulator of the CC, and 3 years just 0.2% compared with the no treatment group and 2.3%. But if the 5 years the accumulator HCC instance and a treatment group just 0.9 and compare with the no treatment group, the 3.4. So whole cost management should be conducted in patients with the high risk of the HCC, and starting from the discover the surface antigen positive, including chronic the hepatitis carrier, the no, even though this patient, the ALT is normal. Also, this no activity surface antigen carrier, and we also should be conduct the management. E antigen positive and the negative hepatitis B, the patient, and also cirrhosis, the patient, we need to the follow up. So this is the show such as the chronic hepatitis B carrier stain, even though this patient may be ALT normal. So we also should be give the patient the regular monitor, such as the every 3 months for this blood routine and biochemistry and the HBV mark and the tumor, the biomark. And even though this patient no special normal, also should be conduct the imaging technology every 6 months, such as the ultrasound and the CT scan, and also fibrosis the detection. If necessary, we also give the patient the liver biopsy. So for this patient, if antiviral treatment indication are met, because such as the ALT abnormal, so should be exposed as soon as starting the treatment. So this is just for China, the 2015 years, the China about the hepatitis B prevention and treatment guideline. This is a guideline just show us when start to the antiviral treatment for the different patient. So according to the surface antigen and the HBV DNA lot and the ALT the level. But the in 2019 year in the China, this the guideline have modified, and this key point is tender indications of the antiviral treatment, such as if the patient, the age over 30 years, have the family history of the HCC, should be start the antiviral treatment, no matter the HBV DNA level or ALT level. So this is the 1, 2, and the early treatment and the early and the delay develop to the cirrhosis or HCC. So no matter E antigen positive or negative, and a chronic hepatitis B patient we need to every 3 months should monitor the regular detection, such as the liver function, HBV serological tests, and HBV DNA. Also, every 6 months should be monitored and CT scan or ultrasound, and if necessary, we give the patient the liver biopsy. So, but now, if the patient aged over 30 years, we also should be careful to, as possible, as the early start to the antiviral treatment. If the E antigen negative, the CHB patient, and now the antiviral treatment should be start as soon as possible, no matter this patient, the ALT the level, even the normal, as long as this patient HBV DNA detectable, so the patient should be start to the antiviral treatment. But if the patient is hepatitis B related to the cirrhosis, so the monitor should be every 3 months, and especially the ultrasound, and also should be in the monitor every 3 months. If we have a nodule, and 3 months, if no nodule, also the cannot over 6 months, and monitor this the CT scan or ultrasound, because we want to find the early nodule and find the early HCC. So antiviral treatment for this patient should be initial immediately, as long as you diagnose this patient the cirrhosis. So for the cirrhosis patient, once the intrahepatic small nodule are found, and if the diameter of the nodule and over 1 centimeter, so we give the patient the contrast enhancing ultrasound or enhancing the MRI should be performed to determine and is this patient have a small liver cancer. But if the diameter of the less than the nodule less than 1 centimeter, we cannot confirm diagnosis for the routine, the immediate examination, such as the CT or ultrasound. This patient should close the follow-up, and even 1 to 3 months, we give the repeat ultrasound or CT test. But once the small nodule are found, we find the nodule and glandular and bigger or progressively, so we should closely and monitor the CT scan and MRI. So if no nodule is the cirrhosis patient, we also cannot less than 6 months and give the patient monitor the immediate. If the patient, the small nodule are found, intervention should be activity taken according to the above the procedure. So even this patient diagnosis the HCC after surgical operation, we also give the patient the monitor and the CT scan, ultrasound every 3 months until it's the long life, the monitor. So if we find the antiviral treatment, this patient, the drug resistance, such as the HBV DNA rebound, so we should adjust via the treatment protocol, because if the DNA cannot separation the low level and even the undetectable, so this patient also have a high risk to develop to the HCC. So other management, just the doctor and patient interaction should be closely, and give the patient continue to come back to the examination. And patient also should be education. As long as this patient HBsAg positive, we give all of this the patient the education about the hepatitis B, the knowledge and how long come back to monitor and detect. This is the above mentioned this detection. So this is the figure just to show us the above mentioned this the measure for the prevention, second line prevention. So for this whole course management in our team, we also have 19 years cohort studying. So all these patients, the whole course the management, we find even this patient also a few patients develop the liver cancer, but 70% this the HCC patient also is the small tumor, less than 3 centimeters. So this patient give the early diagnosis and early the operation, then and the long survival. So in our cohort team, and the over 10 years survival after operation is very over. So this is, I think, contributed to the whole cost management. So the secondary prevention is very important for the HPV-related HCC, the patient, and finding the occurrence of the small HCC is very important. Then give the patient the early surgical treatment or another treatment, then can prolong the survival cycle of the patient, which deserve to be the wider popularized. Oh, thank you.